Could you please introduce yourself also?
Yeah, my name is Norbert Lyon. I'm a physician at the ID Berlin. It's a medical clinic. We provide treatment to drug users in Berlin. And yeah, you have some questions for me, I guess.
Yeah, the first question is, what is your opinion on the methadone dosage?
Yeah, I know that many people feel that methadone should be, the dosage should be restricted to a very low dose of, let's say, 60 or 70 or 80 milligrams per day. I don't believe in it. I think that patients should receive the amount of methadone that they need to feel stable, to not have any craving for opiates. And the dose can be anywhere between 4 or 5 milligrams to even in some cases up to 300 milligrams if need be. I want my patient to not have withdrawal symptoms, and I also want my patient to not be loaded. So the dose should be somewhere between those two extremes.
Yeah.
I also think that in drug treatment, we meet a lot of people who feel they know exactly what the drug user needs, and I don't necessarily believe that. I think we need professional people working in the field, but I also feel that we shouldn't come from a place of knowing it all. We need to really listen also to what the patient needs.
Okay. And the second question is, what is your experience with the concomitant drug use?
Concomitant drug use. In our program, a lot of patients continue using other illegal drugs and alcohol, and also medication that is available in pharmacies. And it shouldn't frighten us too much. We have to work with patients. Once in a while patients have to go to hospitals to withdraw from their concomitant use if they cannot manage to reduce the other drugs over a certain period of time. We always work on helping people to reduce other drugs and to keep them mono-dependent on methadone. But I wouldn't expel anybody from the program because he uses heroin. He still continues using heroin for a while, or using cocaine for a while. I do want to see that people reduce their concomitant use over time. That's something we have to work on with the patient.
Okay.
There is a certain fear. Methadone is still regarded as something very different than any other medication. And my opinion is that in Western medicine we use Western medication not in order to heal anybody. In general, Western medicine is not about, or Western medication is not about healing patients. Western medicine is, in my opinion, a very good method to manage disease. If you compare it with the treatment of hypertension, first of all, you would never give a patient who needs a certain amount of medication to treat the hypertension that the patient has. You would never ask the patient to take less because you feel he shouldn't take as much. You would give the patient exactly the amount that the patient needs to keep the blood pressure stable. The same is true for methadone. Also, high blood pressure medication does not heal the hypertension. The moment you take the medication off, you take the patient off the medication, the blood pressure will go up again. So it doesn't heal the hypertension. Methadone also doesn't heal the opiate dependence, but it helps the person to get access to treatment and to get better. I would even say with opiate dependence and methadone treatment, patients even have a chance to eventually try to stop using the methadone and still stay stable and functioning in life. While somebody who has a hypertension rarely will be able during their life to stop the medication. So chances are even better for people on methadone to get off the methadone than for somebody on an ACE inhibitor to get off that medication, for example. You would never give somebody who needs 40 units of insulin only 30 because you feel that 30 should be enough. There's no reason. Are there more questions?
Yeah, and the last question is, we would like to know that how you can convince doctors to be less restrictive about the dosage.
I think you need to be exposed to a different attitude about working with drug users. You need to see that only when you start coming from a place of also listening to drug users and trying to understand their background and including the patient, which is true in medicine in general, I think, but also in working with addicts. If you start including the patient in the treatment, then you can understand that this is the only way it can work, in my opinion. It never works from, as I said at the beginning, from a place of knowing it all. It's really, of course, I don't mean that you need to give everything the patient asks for. This is very wrong. You need to set very good boundaries. You need to work very clearly. But you need to also listen to what the patient needs. And if the patient continues to use opiates, illegal opiates, then I don't see any reason to not up the methadone dose. Usually it helps them stop using opiates. That's the idea. Why would I give them less if they need more?
Okay.
I want to add that there are many people think that a drug user has started using the opiates and only then they need the methadone, while somebody who has a hypertension or a diabetes is just sick, while opiate dependence is some moral defect or some problem that people have created themselves. And I don't know so much about how it is created and how much it is genetic or whatever. It doesn't really interest me so much. But if you look at it from the other side, also many people with hypertension or with diabetes have, or lung cancer for that matter, have contributed a lot to developing these diseases. And I don't judge them for it. If somebody has lung cancer and the lung cancer is potentially related to smoking for many years, I don't deny treatment. I don't say, well, you only get half the dose of the whatever medication or radiation you want to give, or you don't get the surgery. You only cut half of your lung off because it's your fault, you know. So I don't see any difference there, and I don't see why somebody who is on opiates and who can have a relatively normal life on methadone shouldn't get exactly the amount of methadone that they need to be off the opiate. Okay, so that's I've been working in this area for about 20 years, and I've worked both here and in other places, also in the United States and in other places in the world. But the only way, in my opinion, to work with people who use drugs, who have used or still use drugs, is to not be judgmental. First of all, if you have judgment, and this is true for anything really, if you approach somebody that you want to work with, that you want to get better, if you confront him with a lot of judgment, the usual reaction is that people don't get better. People just may obey for a period of time because of the restrictions, but they really don't make a change. Change can only happen if people understand that you actually follow them, that you actually try to see where their problem is and try to work out solutions with them. And again, I'm saying also that sometimes understanding people and working with people means to put very clear and hard boundaries. But it's not about coming from a place of arrogance. That I've never seen it work anywhere. That's really my opinion on that.